started. So we only have only one of our discussants is here at this moment, and we'll just let everybody else kind of hop in. I know it's pretty busy, and obviously patient care supersedes doing any kind of educational stuff. So so today we're going to have a case with Sam is actually going to be our only discussant at this time, but everybody else is totally free to hop in and either unmute themselves or put in the chat if they have any ideas or any other questions or anything that they want to ask. And Danny is going to actually present the case for us. So, oh, look, Jason John's here too. So Jason and Sam will be our main discussants. And then if anybody else wants to chime in, you're more than welcome to, but I'm going to direct all my questions to Jason and Sam. So without further ado, I'm going to let Dr. Gergen take over and tell us about this case.
And I've got Devang.
Perfect. Thanks, Corey. So for our case today, we have got a 34-year-old gentleman coming in with a chief complaint of blurry vision. So he's had a 3-week history of blurry vision, notably, worse when he's kind of looking towards the edges of peripheral vision, looking up and down. It's been associated with some mild right-sided headache. And then over the last week or two, he's developed a little bit of mild right-sided hearing loss and ringing in his ear. He says he's never had these symptoms before. He denies any fevers, chills, shortness of breath, chest pain, other abdominal pain. He says that he's not sure what brought this on, but he's coming into the hospital because his blurry vision may be getting worse.
All right, I think that's actually really good. So I wanted to
You got it. Cool. Sorry. Kind of a moment here in this history of this person's got, just while Danny's typing it, blurry vision, 3 weeks, right-sided headache, a little bit of now hearing loss, ringing in his ears. Any other questions that you guys want to ask him at this point?
Can you describe the blurry vision anymore, like double vision, or does he have any other sort of descriptors?
That's a good question. Why do you ask that, Sam?
I don't know, just trying to get a little more idea if I can localize this at all.
Yeah, that's great. Any of that, Dr. Gergen?
Yeah, great question. So he describes it as right eye vision loss. He says he's seeing colors are a little blurrier, and he feels like his vision is overall cloudier. And perhaps he's not able to see the edges of his vision as well as he used to, but the predominant issue is a problem with colors and more cloudiness.
Any other?
Yeah, so,
go ahead, Jason.
Can you guys hear? And I'm here with Devang too. We're going to tag team this one. On a very fundamental level, I think what Sam was getting at, I think if a person is having double vision, either just when they're looking straight ahead or when they look in a single direction, you start to think about some kind of gaze palsy. So basically, whether by the muscle, whether by the nerve, the ocular motor function of the eyeball itself is off. I'm not hearing that. What I am hearing is obviously there's a problem with the visual fields. So there could be some visual field deficits. And then also some like blurriness, some problems with color. I know there's some opto prelims out there listening to this. I don't want to sound dumb, but it sounds like the actual visual acuity and something could be wrong there as opposed with the movement of the eyeball.
Yeah, and as limited as my ophthalmology expertise go, I think you made some really good points. Thinking about double vision when they're looking laterally or up or down totally makes you think of having some kind of palsy that's actually causing you to have this double vision. One of the big teaching points that I actually heard from an ophthalmologist, he said, somebody comes in complaining about blurry vision to us internists. I'm like, when do we actually need to? Yeah, actually, that's perfect. Graham, that's a great point. Talking about monocular versus binocular diplopia. And one of the things that he made a point about when us internists hear about somebody coming in with blurry vision, he said the time you need to really investigate this more is when an individual says that they cover one of their eyes and the blurry vision goes away. that's more concerning than somebody just saying if the blurry vision is persistent, even though both eyes are there, which kind of makes sense because it probably means it's isolated to one of the eyes instead of some kind of like global sensation, like of dry eyes or something else that's kind of causing them to have this blurry vision. Kind of one of the, so that's kind of the big teaching points from there. So any other big questions that you guys have for him right now, or does this sound pretty good? I think we've got a pretty good HPI. So why don't we go into his past medical history, social, family, and then we'll start getting differential.
Perfect. So a little bit of additional HPI, which you pick up on your kind of second time talking to the patient. He states that you ask about past medical history, and he states that he was hospitalized or at least seen in the ER a few months ago for a rash across his body. He states that he wasn't diagnosed with any particular type of rash, but was told he had a rash and was given a topical cream. Other than the rash, he denies any other prior past medical history. States that he does use meth on a regular basis.
What was the rash like? Can you tell us anything else about what it looked like?
Sorry, Sam, what was that?
What was the rash like? Can you tell us anything else about what it looked like?
Anything with that rash?
Yeah, good question. He says it was a red rash across his body. He doesn't particularly remember where it was located to, but thought it was sort of just everywhere on his body. He says that after he started the topical creams, he didn't notice much difference, but eventually the rash went away, and he's not sure why.
How does he use the meth?
Devang, did you have how does he use his meth?
Yeah.
Great question. So he does both injection meth use, but he also smokes meth. He says that he splits his time between the two types of meth about 50-50.
Okay.
Why do you ask that, Devang?
I'm wondering if he's got like endocarditis and is throwing septic emboli. Like potentially his brain, or maybe that explains the rash a little bit. Doesn't sound like it with the rash, but could be.
Yeah, totally. I think like thinking of something like a more peripheral rash, like something on your lower extremities, on your obviously like Osler's and gangway lesions on your like distal like digits is something to think about. And Sam, I didn't get to ask you what were you thinking about him describing the rash? Anything like details that you'd want to know, make you more suspicious of one thing over the other? Or?
Just like if it maybe sounded like viral, like could this be explained by sort of viral involvement of CNS, or if it was like painful or itchy, if maybe it sounded like allergic in nature. It doesn't sound like he had like a whole body exhaust or just drug reaction.
Yeah, that's those are really good points. I think like thinking about like does this guy have a zoster rat? Like did he have disseminated VZV? Does it, what is it? Ramsey-Hunt is the syndrome where you can get VZV isolated to your like cranial nerve 8, I think, and it's severe. You have loss of hearing, you have painful hearing or pain on that side. So yeah, I think definitely kind of giving you a description of the rash as much as detail as you can really kind of help differentiate things. Okay, I think if we're good on the past medical history, we'll go into med, social, and go from there.
Great. So social history, he states that he smokes and injects methamphetamines quite regularly, but doesn't give you a specified time. He does not drink alcohol. He infrequently uses marijuana and denies any other illicit drug use. He has experienced intermittent homelessness over the past few years and states that he's been homeless more often than not in the past 6 months. He states that he's sexually active with women only. He does not answer your question as to whether or not he uses condoms or any sort of protection while having intercourse. And his social history is otherwise unremarkable. He does not use any medications outside of the topical cream he got for his rash. He has no relevant family history, and he's not allergic to anything.
Okay, good. So why don't we do this right now? So if our discussants can take 15 seconds to think about a differential diagnosis they have at this point, and then anybody is welcome to, like, if you have anybody that's in the room with you that you want to like kind of gather your own differential that you're kind of thinking right now for this gentleman, we will kind of you can check that, you can unmute yourself and let us know. What discussants? What are y'all right now for the differential?
I think we got to add neurosyphilis under the differential because that can actually present with basically any kind of neurodeficits.
Why do you, what kind of draws you? Is it neurosyphilis just because neurosyphilis can kind of present any way, or is there anything else in his history that makes you?
Yeah, with regards to his social history, he's not answering your question on whether he's using any sort of protection. And it sounds like with history of, this, I don't know how many partners he has.
Good. Why don't we see, do you guys, I know obviously high differentials or high differentials and hearing loss is pretty tough, but why don't we get like 2 or 3 more things that you guys can think about that y'all would want to, y'all are at the top of your list or that you worry about with this gentleman?
I worry about some sort of like primary CNS lesion in him. I don't know what it would be, but like right-sided hearing loss, tinnitus, right-sided visual change. I can't think of like one area that would affect all of that, but worry about some sort of CNS mass or something that could be compressing multiple cranial nerves.
Yeah, actually, I really like what you did right there, because I think what you really harped on is you're like, anybody that comes in with neuro deficits, I think everybody should try to see if they think it's something central nervous system, is just to see if you can kind of locate where that is. And the reason why is because your investigation is gonna be more tailored to where do you think this is. Sam, you made a great point, like trying to link all these neuro symptoms into one spot it's a really good way to kind of differentiate and work up somebody who's got new onset of symptoms. Looks like Graham says possibly vasospasm causing ischemic insult. So Graham seems like thinking maybe a stroke. And Graham, if you were thinking a stroke, where do you think the stroke would be? MS, yeah, that's good. Yeah, good job, Victor. I like that.
I think along with vasospasm, vasculitis, like if this rash was maybe petechial, and then he has multiple like CNS lesions.
Yeah, good point. Yeah. One vasculitis that Danny Gergen is very passionate about is reversible vaso. It's CNS. I don't even remember what it is. I think it's RVNS. But yeah, something. Usually that actually has a thunderclap headache is kind of what they think. But I think something that kind of linking CNS vasculitis and possibly like a diffuse kind of cutaneous vasculitis as well. I think it's really good to think about. And good. Anything else? I think this is a pretty good differential to start off with. So I guess before we get to the vitals and physical, I want you guys to tell me, you got this guy's coming in with these blurry vision, hearing loss. What physical exams are you going to perform on this guy?
Full neuro exam.
I'm going to push you a little bit, Sam. What do you want to test exactly on him?
Like cranial nerves, visual fields, visual acuity too, if you have that available to you. It's harder on the inpatient side. And then not as much concern about extremities, but at least checking like basic strength and sensation and reflexes.
Yeah, I like that. That's really good. I think, doing a thorough cranial nerve exam and especially testing his visual acuity or his visual fields and visual acuity is a really good one. Devang, Jason, anything you guys really want to hone in on as well?
I guess a good like skin exam. Not that we do a great job of that collectively as internal medicine doctors, but it'd be good to see if he has any rashes anywhere. And then, obviously taking a look at his eyes itself, seeing if there's any like he has really red eyes, if he has any lesions on or around his eyes or on his face, I think would be important.
Yeah, I like that. I think that's perfect. I think, even just, obviously testing the nerves, but also looking at the eye itself. I think somebody comes in, one of the things to think about, somebody has blurry vision, things to think about. Does this person have glaucoma? Does this person have a uveitis? Is their eye like injected? Is it like scleritis, iritis, all the itises that go with, like that. Good. Yeah, all the itises of the eye that you wouldn't, with our limited exam, you kind of need to be concerned about. So, obviously, like one of the other things, think about somebody with blurry vision, which we didn't get in the history, but does he have eye pain itself, and does he have pain with eye movements? What kind of things do you think about with like pain with eye movements?
MS.
Yeah. Yep.
Think about some lesion that's making it difficult for the lateral rectus to contract, for example, if he's having trouble with diplopia there.
Yeah. So that's, I think so I think all you guys are getting at the right things. And one of the things I always think about, like orbital cellulitis or uveitis. Usually these people have like really bad pain in their eyes. They have photophobia in addition to these blurry vision. Also acute closure. Oh my God. Acute glaucoma. Also, you're going to have acute angle closure glaucoma. You're also going to have severe pain in that eye too. And what's kind of classic thing that they comment about in acute angle closure glaucoma about their visual fields or vision? It's like they usually see like halos around light, I think is what it is. So unless somebody can tell me I'm wrong, I can't remember if that's open angle or acute closed angle. But
this is also like really anecdotal, but whenever I've had somebody with that and I just tap on their eyelid like very gently, it's exquisitely tender and actually feels like a little tense.
Yep. Yeah, exactly. That's actually another thing. Good point. And I think whenever like you can actually, I know we don't have the like actual ability of the device to measure the pressure like they do in the ED and with ophthalmology, but you can just do compare the opposite side to that side and see if it actually feels more tense than the other side, and that can actually give you a lot of answers about if you're worried about glaucoma or not. So cool. I think that's good. I think we covered a lot of big things that we want to work on this guy. So I'm going to hand it back over to Dr. Gergen, who's going to go over his vitals and physical.
All right. So on his initial vitals in the ER at our hospital, he was afebrile. His blood pressure was 100/55, pulse 66. He was breathing 14 times per minute, satting 98% on room air. He had an excellent physical exam done by one of our residents, Michelle Canese, on exam. He was well-developed, wonderful. He was not in acute distress. He did not have any clear head, nose, and throat issues. On cardiovascular exam, he was regular in rhythm with no murmurs, rubs, or gallops. His pulmonary exam was normal. Abdominal exam was normal. So what you guys were most interested in, his neurologic exam, he was somnolent but awoken to loud voice and tactile stimuli. He was ANO ×4 with prompting as he kept falling asleep. His right pupil was 3 millimeters and reactive. His left pupil was 6 millimeters and minimally reactive. He was moving all four extremities equally and symmetrically. He had normal strength and sensation in all four extremities. His visual fields were intact, and his visual testing also appeared intact, though was limited by patient participation. On his skin exam, he was warm and dry, but did have various scabbed lesions across all of his upper and lower extremities, which he told our resident were at sites of prior injection. She noted that he had no erythema or fluctuance around these sites. And I will type all this in as a summary.
Sorry, Dr. Gergen's pulling a double duty right now on reading the HPI or reading this case and doing the typing. So I appreciate him a lot. So, so anything else that you guys would want to perform on this?
So, like, really quick clarification. You said the people on the left, I believe, was minimally reactive. Do you test like with accommodation and with light?
Great question. So accommodation was not tested based on this HMP. but with light, the pupil did not react.
But with accommodation, minimally reactive.
There was no accommodation tested on this exam.
Why do you ask about that, Devang?
Like there's that Argyle Robertson people with neurosyphilis. You can get these people that are reactive to accommodation, but not to light.
Yeah. Do you have a way that you remember that?
Prostitutes people
Yeah.
accommodates but does not react to light.
No, but I think
You asked a question.
no, I know, and I think it's a good thing it's just a good way to remember these things. But I agree, like that's how I remember it too. Is just remembering that you get accommodation, but don't get the reactivity when you shine light on it.
Yeah.
Okay. Anything else that you guys want to know from this physical exam, or?
Do we do anything I mean, this is probably like a moot point at this point. Did we do things to differentiate between upper motor neuron and lower motor neuron stuff, like reflexes or anything like that?
Reflexes are normal from what I'm gathering.
Okay, cool. Thanks.
Okay. All right. So why don't we go ahead and let's get to the labs and imaging and stuff. And so besides getting the ER handshake of the CBC and BMP, what other labs would you guys want to get?
Syphilis.
Which syphilis test would you order?
Oh man. I believe treponema antibodies is the preferred first one now.
Yeah.
Then you do RPR as like the reflex antigen. And then yeah, I think so.
Yeah, that's actually exactly right. So the first thing that we always do now is like I think 3 years ago we changed it, but 2 years, even maybe 2 years ago, but now it's FTA antibodies, which is treponema antibody, and then if that's positive, you get the RPR. It's like Victor's putting some good things on there. He wants to get an HIV, ESR, CRP. Graham, I don't know if you have a microphone. Tell me what you want to. What are you looking for with this LP? With that, what's that ERDL or? Yeah, not mic'd up. Does any one of our other discussants, can anybody kind of elaborate on what Graham's looking for right now?
So I think I can. If he's talking about a VDRL, if he's looking for neurosyphilis, is that what you're talking about? So actually, this is interesting. I had 3 cases of neurosyphilis in my Denver Health Awards month last month, so I know a thing or two about it now. And basically, a CSF VDRL is obviously diagnostic for neurosyphilis, but it's not very sensitive at all. So if someone has serum confirmed syphilis, and then they have a CSF with a lymphocytic pleocytosis, that is diagnostic of neurosyphilis. So yeah, we would order the VDRL, but we could just actually we could get the serum testing and get a cell count and make a diagnosis based on that as well.
Yeah, and actually that's fine. I've taken care of a neurosyphilis patient or two as well, and you're right. Like the VDRL is, I think it's actually not very good at all. I think it's like 75% or something like that. And I think actually from what I was looking up to date, when I had this other patient before, I think that's what it is. But like I think it's better in patients who have HIV. It's more often positive than not. But I think the other thing that you can do with the VDRL is you can actually monitor these patients too if they have recurrent neurosyphilis. So it's probably good to like add it on. But like you said, you have peripheral positivity, and then you also have a lymphocytic pleocytosis. I think you're spot on about that. And then Victor, I don't know if you can elaborate on what you're wanting with those monoclonal proteins. I don't know if you have a microphone or not. Victor might not have the mic on. So there we go. Yeah. You're right, Victor. That's right. Actually, it is actually that's what we usually think about these. It's actually oligoclonal bands is what they typically think on the LPs. But it's kind of the same thing. It's just looking for antibodies in the CSF. And Dr. Gergen, do you have anything to add about oligoclonal bands in the CSF?
Yeah, so oligoclonal bands in the CSF are indicative that you've got some infectious or inflammatory process in the CSF, but by themselves are not necessarily diagnostic for MS, which is what our common test question is. So just getting oligoclonal bands is not specifically diagnostic for MS and really should just raise your suspicion for an inflammatory or infectious process.
And like obviously ESR-CRP inflammatory markers will be useful here.
What would those be useful for you, David?
I think like figuring out if we've got some infectious process on our hands. It would be really, really weird to have like septic emboli being thrown up there in different spots, but I think like anything is possible, just to keep things broad, and then be some process. I don't know. In MS, you don't see that.
No. I think that's good. I think one of the things I like also typically think of, if you're keeping this guy's got this rash, you kind of you're worried about vasculitis. The vasculitides usually have pretty high ESR-CRPs, and so I think keeping that in the back, evaluating for that too. It doesn't rule it out necessarily if it's not there, but can there's suspicion for it. So I think those are totally reasonable. Perfect. Okay, so we'll get let's go ahead and get the lab work of the CBC, BMP, HIV, ESR-CRP, and then LP studies if we have them. Yes.
All right. So as you are putting in your lab orders, the medical student that you are working with walks up to you and says that she retrieved some results from the outside hospital that the patient had apparently been at 2 months ago. All the results say on the discharge paperwork is you have MS and you should be treated with further IV steroids and prednisone. Please return for your follow-up appointment in 2 weeks. You bring this up with the patient and the patient does not know what you were talking about.
So I guess can we just treat him with IV steroids and send him out on his way after we get done and no more workup, or?
Oh, no way.
So I think we have to have an appropriate level of skepticism of the diagnosis. Like certainly if this gentleman has had an MRI with ideally the images, or at least a report that shows kind of the classic like MS lesions, I think we can take a little bit more seriously. But a clinical diagnosis of MS with these symptoms without some objective data to support it is not good enough for me, unfortunately.
So I'm gonna push you a little bit here, Jason. You said something about some MRI findings that are classic for MS. What do you mean by that?
So I think what you're going to see is, and I'm forgetting the name of the fingers, but basically you're going to see classically you'll see in the cerebrum, you'll see periventricular enhancement. And then you can also see, enhancement in like different areas of the spine as well. You can get MS lesions there, but you would see some areas of enhancement on the MRI. Dawson's fingers. Thank you. That was Devang.
Yeah. There's you're right. So the classic thing that we see is this. The classic thing that we see is these periventricular white matter disease is what it looks like, and so these plaques kind of irradiate. And there's actually like, I was on neuro and the neurologist like explained it to me, and it like went out like 10 minutes after he told me, but it made a lot of sense what he said actually. But yeah, it's these Dawson fingers with these projections and the periventricular white matter disease. And then Victor's already thinking about getting this guy retuxed, so we should go ahead and rule him out for all the infectious stuff. So I like where your head is at, Victor. So so you guys, it sounds like you guys still want to push forward with our workup that we're doing. So let's see what kind of shakes out from all this.
Perfect. So I am just going to give you guys the relevant lab results because I'm going to develop carpal tunnel otherwise. So relevant lab results from admission. His CBC, he has a white count of 9.8, a hemoglobin of 14.3, a platelet count of 249. The differential on his CBC is normal. His BMP is entirely normal. his TSH is normal, his B12 is normal, his LFTs are all within normal limits. In terms of infectious studies, which you guys have all hinted at, his TB, his quantiferon gold is negative. His chlamydia, trachomatis, and Neisseria gonorrhea urine studies are negative. His COVID study is negative. His HIV study is negative. Hep C is negative. His cryptococcal antigen is negative. Patient does not consent to a syphilis testing at this time, and patient declines an LP after you try to consent him for this procedure.
So what do you guys do with this workup that we have, or the data that we have at this moment?
Not a lot of answers so far. I think we need some imaging.
Perfect.
We agree. If anything, it doesn't absolutely rule out an infectious process, but you know, some of the things that go lower on the differential or some kind of raging, like infectious meningoencephalitis. You know, like I'm trying to see what else we had on the differential. You know, like a flare of a vasculitis, not sensitive or specific, but you could see, you know, leukocytosis. I think that's pretty much it as far as things we realize. And then the fact that his HIV is negative, that's you know, that puts like some like opportunistic infectious processes like kind of down lower on the list.
Yeah. Yeah, I like that. I think that's really good. I think you're kind of, I think it's, you know, even though we have limited amount of information, I think like, you know, other thing to think about is like you can totally, people can get a, HIV can manifest in odd ways too. And I mean, obviously you can have an HIV encephalopathy and HIV encephalitis. This guy's a little bit of time. So kind of thinking about things like that. With his HIV being negative, that obviously takes that out as well. So, but I think, you know, looking at this list that we have, which really good differential, you know, I think you pointed out MS vasculitis, neurosyphilis, and CNS mass lesions, I think are, and also like a vasospasm is still definitely a potential for us to consider on this. So I think until we get imaging, I think we're probably a little bit, we're kind of at a standstill at this moment. So that's probably our next course of action. So what do you guys want to do for imaging?
I think I would want an MRI brain with and without contrast in this case.
Why not a CT head?
I think like the sensitivity there for looking for specifically like MS lesions or abscesses would be a little lower. It's good for looking for bleeds, but I would think you're not going to see as much there.
Sam, Jason, what about you guys? CT head, MRI brain?
I think,
You know, oh, go ahead, Sam.
I was just going to say, if the CT head came back normal, I think I would still want an MRI. So obviously the CT could have something glaringly abnormal if there was like a large mass, but I think that I'd probably go to MRI just because I wouldn't be reassured by a normal head CT.
And even if there was a mass on CT, the next step would be an MRI. This is a subacute process. So, you know, like an acute hemorrhage, you know, like, again, like an acute insult to the brain where you have like swelling and stuff like that. All of this, like, it's less likely, and anything else that we could find that's more subacute would want to move towards MRI. So actually, if we're going to get imaging, I think I would lean towards going directly to MRI. The other thing I would add for imaging, we didn't really talk about this earlier as far as symptoms, and we didn't really talk about it on an exam, but I would get a chest x-ray. And the reason I would is we didn't ask about if he's having any ptosis or like anhidrosis if the exam was just exceptional. So in the differential for like a unilateral pupillary restriction is Horner syndrome, and then the differential for that is especially in like a young person is or in any age person is like a Pancoast tumor, so an upper lobe lung tumor. So I would get a chest x-ray.
Nice. I think that's actually a really good point. That's actually something I didn't even think about, but asymmetrical pupils, if, you know, obviously they didn't comment about ptosis, but if this gentleman had ptosis, if he had anhidrosis, always thinking about trying to link things together. And I think that's a really good thing to think about Horner syndrome, which I wouldn't even thought about. So I appreciate you bringing that up. And Graham, and yeah, Graham's thinking about maybe an MRA, get a vascular imaging too. That's a good point. You know, I mean, so Graham, do you know what you would kind of see if you had like a CNS vasculitis on there? Like, what's your classic thing you're going to see? I know. I also give him like a second to type, and then I'll open it up to everybody else to. Kinda. There's Sam, and Devang. Anything that you kind of classically see on imaging of like seeing like you CNS vasculitis, you see this in PAN whenever they have that vasculitis as well.
You
So it kind of looks
like beaded appearance of a vessel.
Wait, what'd you say?
Sort of beaded appearance of a vessel.
Yeah. So it's classically that bead on a string kind of look, and it's like areas where it's constricted from inflammation, regular size, constrict, regular, and so it kind of has that beads on a string look too. So because we're not formal radiologists, probably don't have to belabor all that too much. So why don't we go ahead and get to the imaging of the MRI brain that they got? Or did you guys? I think we agreed MRI brain was the first order that we wanted to do. Okay.
All right. So again, we are not radiologists. I'm going to give you the read here. So the official MRI brain and MRI orbit showed mild burden of scattered frontal lobe predominant white matter signal abnormalities that are nonspecific. Findings could be associated with demyelinating disease or infectious etiology based on prior LP studies, if not obtained. Correlate with CSF and outside imaging if possible. It also showed optic nerve enhancement on the right side. Chest X-ray was unremarkable. The diagnosis will be revealed in the next set of information.
Does that information help you guys?
And did that have vessel imaging, or was that just MRI, not MRA?
That was just an MRI.
Well, it gives us a target at least. I mean, there's something abnormal going on in the brain. In some ways, it's more helpful than a completely normal MRI.
Yeah.
But I think what's concerning is, you know, I know they say the findings could be consistent with demyelinating disease. This is beyond my area of expertise, but I wonder if like someone looking at the imaging would look at the distribution of the lesions. It's just scattered frontal lobe lesions. I don't know whether they're around the ventricles. I don't know whether they're in a pattern that's classically seen in MS. What I'd be very concerned about in this particular situation is that there's in fact an infectious process. Doesn't sound like a bacterial pneumonia, a bacterial meningitis, just based on, you know, his vitals, based on his blood work. Like, these people are a lot sicker. But what is possible, especially with him being homeless and having risk factors, is so more of like an atypical meningitis, so TB certainly, and I don't think we had those results back yet. Also a disseminated fungal infection as well. So blastohisto cryptococcal meningitis. I would not want to give someone in that situation steroids, because I can make the situation worse. So I forget if we've already ordered it and it's just pending, but I would want to, before I proceed with steroids, I would want to get some fungal serologies on this gentleman. And I would want to, at least do some kind of TB testing. If I have to do quantiferon, like, I'll do that. But I know at least with like active pulmonary TB, sometimes it doesn't capture that. So.
Yeah, all really, really good points. I think you actually, you kind of elaborated on a lot of things that it's still like, you know, we still have an infectious workup that we still haven't completed and that we need to get done. And so I guess, like, say right now, patient still is like, I'm not going to let you test me for syphilis. I'm not going to let you stick a needle in my back. This guy's complaining about blurry vision. What would you guys do at this point?
You know, another thing we could do, I'm just throwing it out there. We do have ophthalmology colleagues, and the discussion I would have with them is not to get them on board. I would have a discussion with them about potentially doing a dilated eye exam to look at the retina, because obviously like they can it's the only direct look at the blood vessels that we have in the body. So they could take a look at it and see what they think.
Yeah. Yeah, no, totally. I actually, to be honest, I would go if somebody has blurry vision, that, and either like and they have like decreased visual acuity that's asymmetrical, that wasn't documented before, or they have an anisocoria that he has with like asymmetrical pupils. I think calling opto to do a fundoscopic exam on this gentleman is totally reasonable. And the reason why is because you can get answers if this is like an ophthalmologic process, like actually in the eye. And if they don't see anything different, then you can say, hey, this is probably something in the brain. And so it can actually be a really good tool for you to help in your diagnosis. So I agree. I'd call opto, and I'd say just get them, tell them the symptoms, everything. But sounds like from what
Corey, one more thing. I know he has a bunch of scabs all over, and he had a rash previously. If I was really having a hard time diagnostically and he was refusing certain tests and certain interventions, and I had a concern about some kind of disseminated process, whether it be like a metastatic cancer, whether it be a disseminated fungal infection, if there was a lesion that didn't look like just scab tissue, I would have a low threshold for trying to get someone, namely the dermatologist, to biopsy, do a skin biopsy, because sometimes that can be diagnostic as well, of both vasculitides, of infection, like fungal infections, and also of sometimes, metastatic cancers if they go to the skin.
Yeah, you make good points. I mean, like thinking about T-cell lymphomas, just lymphomas in general, just odd things that can present in the skin that we are like not used to, that probably don't look scary to us. I think it's a good point. If he has a lesion that looks like it's been there before, doing a biopsy for some infectious vasculitis, all those stuff is good. I think Victor make a good point. Calling neuro as well, either opto or neuro, whoever you decide to go with first, I think is the way to go. But I think calling them would be the right next thing if this guy's refusing on this. But it looks like, from what I'm gathering, is he actually said, all right, fine, you guys can check me for syphilis and do an LP on me now. So we'll see what those results show.
All right. So you were persistent. Ophthalmology was consulted, and ophthalmology diagnosed him with pan-uveitis and recommended that you perform an LP and test this gentleman for syphilis. You explained the situation to the patient, and the patient agreed and consented to the procedure. On his LP, he was found to have oligoclonal bands and a positive CSF VDRL. His serum studies returned positive for an RPR with a ratio of 1 to 128, which is substantially elevated, leading to a diagnosis of neurosyphilis.
I'm going to share my screen real quick and just kind of go over with you guys when you get a positive FTA antibodies, like what is your next process in the whole, what is your next process in management and diagnosis of this? So say this gentleman, he has positive FTA antibodies, what comes next? Yeah,
I think Victor answered it. RPR.
Yeah. So RPR comes next. And then if you have a positive RPR, that's diagnostic. So what do? We treat people with, say he's got a history of syphilis, and we treat him with penicillin. What do we do for how do we evaluate him for clearance of a syphilis?
No, I mean, I suppose you could check the antigen levels after. I don't actually know.
Yeah, well, I'm trying to think. I'm probably going to get this backwards. The antibodies will probably be there forever.
Yeah. So what are you going to check?
So I think you'd have to check RPR VDRL in the future.
Yeah, so Grandma's you got it right. So you're actually going to check their RPRs, and the reason why is the RPR is actually going to be the one that's fluctuating. It's actually like a so it's a non-treponemal test that's monitoring your syphilis. Monitor or is a non-treponemal test for syphilis, and so when you get treated for syphilis, it actually goes down. And so when you treat somebody with syphilis, their RPR is going to be their RPR should go down. If it's not down, and there's like I can't remember the exact number, if it's like 50% or whatever, like if it's not decreasing, then you might have to continue treatment for a little bit longer. So, but I think what I looked at, you recheck it in 3 months and then recheck it in 6 months after that. And then I'm going to just give you a scenario. So say you got a person who comes up FTA antibody positive, but RPR negative. What are you going to check for at this point?
They have previously been exposed and cleared the infection or got treated, or I think we learned this from Danny. Is this the one where like is the RPR a fluorescent test?
That is, I don't know. You're kind of getting out of my pay grade right now, Devang.
Danny told me something about how one of the fluorescent tests can sometimes be negative if you have so much of a load of syphilis that the whole background cannot be blanked. So then you end up with a falsely negative test.
It's actually, Danny's saying it's the quantum ferron that you can have that when you have so much TB that tuberculosis is coming out of the ears, it can cause this. So yeah, so the Victor, you got a good question. So the whole thing about cross reactivity, it's actually the RPR that you're going to have cross reactivity. If you think about it, that's the non-treponemal, while the FTA antibody is the treponemal. So what you do actually with this is, like you said, does this person actually have a history of syphilis? If they don't, and they've never been treated for syphilis in the past, you're actually going to check a second antibody, a treponemal antibody that's like, I think there's a P, maybe a Z or V, I don't know. But it's you can just type it in there and you'll actually have a second treponemal test. And if that antibody is positive, they have latent syphilis. If it's negative, then that's a false positive for the FTA antibodies. Does that all make sense? The reason I bring that up is I've actually had a patient that actually had a FTA antibody that was positive and an RPR that was negative, and his confirmatory treponemal antibody came up positive, and so we had to treat this like 66-year-old man with no history of syphilis with penicillin. So it's good to you'll come across this, and you can obviously just look this up, but it's good to kind of have a basis for it. I think the good teaching point from this is that, neurosyphilis can have eye findings, it can have an aseptic meningitis, it can also have ear findings too, which this gentleman also had with that loss of hearing, and ENT was consulted and they said he could have like syphilis ear inflammation. So I could have looked it up, but I didn't. But yeah, so anyways, it's another thing to think about. So when you have neurosyphilis, you can actually have a variety of findings. Yeah, so we don't use we're not using syphilis or we don't use VDRL right now for any of the diagnostic purposes. Right now it's the FTA antibodies, RPR, and then if that's negative, and the FTA antibodies positive, you go to a second treponemal test. Yeah, VDRL is in the CSF, which we kind of were talking about earlier. But cool. Any discussants? Any other like cool teaching points that y'all had about this case? I think y'all brought up some really good points on somebody coming in with acute blurry vision.
This is just like a social issue. But at Denver Health, this happened with one of my patients, that he was an IV drug user, and so he was not actually a candidate for OPET. So he either had to be admitted to the hospital for his IV penicillin for his entire treatment, which is a complete pain, or had to show up every single day in an ID clinic. And he had a history of actually like non-compliance with this in the past. So you sometimes run into some interesting social stuff there.
Yeah. And Devang, do you know how long you have to treat with IV syphilis for?
Really? 14 days.
Yeah, it is. And that's one of the things that I appreciate you bringing that up. The other things to think about is when you have neurosyphilis, you actually treat with IV penicillin, and the other ones you're actually going to be treating with IM. So, so this is a little bit more constraining on these patients. And like you said, obviously, these people who have syphilis are they have high risk behaviors, and so there's potential that some of these individuals could be IV drug users, and so you'd have to have them in the hospital for the entire course of the antibiotic treatment.
One thing that's kind of peculiar to me, so what were those lesions on his MRI?
Yeah, we actually didn't. We ended up not actually figuring out what those were. The interesting thing too is because they weren't like classic. They didn't look like classic MS lesions, and I don't know if they're secondary to the syphilis or not. The other interesting thing that on this gentleman is that he actually did have positive alloclonal bands on his CSF studies. So it is also kind of one of these things he's a great example of these, just because you have positive oligoclonal bands and these kind of differentiating kind of odd neuro symptoms, it's not a diagnosis of MS. And one of the things that Danny pointed out before is that when it comes to MS, when you come in a diagnosis of MS has a change in neurosymptoms over time and space, and so you have different neurosymptoms at different times that relapse and remitting. And so keeping that in mind, it's kind of hard with this gentleman who's got 3 weeks of symptoms with nothing other kind of neurologic symptoms before. But yeah. I think that's pretty much it for me. Any other big questions from you guys?
No, I haven't heard the term pan-uveitis. What's the difference between pan-uveitis and uveitis?
Yeah, so there's usually an anterior and posterior uveitis, and so I think the posterior uveitis is going to involve the core, it's pretty much the retina, like the vasculature around that, and then the anterior uveitis is going to be like, I think, the anterior globe aspect, and so pan-uveitis is anterior and posterior uveitis. Good question. And usually, I mean, obviously, us being able to differentiate the uveitises are kind of over our pay grade, but they do actually help in the diagnosis of the ophthalmologic issues and like what's the etiology. Cool. All right. Thank you so much, everybody, for participating. I'd like to thank our discussants, Dr. King, Dr. John, Dr. Amin. Thank you guys so much for participating today.
That was a cool case. Thanks.
Yeah. All right. Okay.